So a very common problem nowadays in adolescents, especially young women, is a problem of recurrent dislocation of the patella or the kneecap. So what is this problem? What predisposes this particular age group to this, and what are the treatment options? Hello everyone, I am Dr. Aditya. Welcome to our channel of the Shoulder and Knee Clinic, where we discuss various issues pertaining to the shoulder, sports injuries and arthroscopy. So well, if you see, normally your kneecap is like this. It is kept in the center of this shallow groove here known as the trochlea, which you can appreciate here. So the shape of the kneecap is also like a V, which stabilizes it in the center of the trochlea. Now, in addition to this, there are ligaments on both sides of the kneecap. There are muscular forces acting across the kneecap, which will provide stability to the kneecap. In some individuals, after trivial trauma or any injury for that matter, the kneecap can come out. So typically when the knee is injured, the kneecap slides out and stays here. It's a very painful episode. Now since it goes out here, the ligament on this aspect of the kneecap or the MPFL gets torn in all cases of patella dislocation. Now once it is put back, generally the ligament heals well, but whether an individual is predisposed to recurrence of the problem depends on anatomical factors. So when an individual initially presents with a dislocation of the kneecap, it is probably the most painful episode. Once the kneecap is put back, generally a brace is applied and the pain subsides. So typically with graded rehabilitation after the first episode of dislocation, 80% of individuals don't have a recurrence. But what about these other 20%? Well, there are certain factors in these 20% of individuals which predispose them to a recurrence of the dislocation. So what are these factors? One, if there is an associated abnormality in the bony shape or a trochlear dysplasia. So that means essentially this is not like a V, it is like a flat, or there is a bar here of bone which predisposes that individual to dislocation of the kneecap, and even after the first episode they start dislocating and there is a very high risk of recurrence. Certain individuals, the knee rather than being straight is in excess of valgus. So the knee is essentially like a knock knee. These individuals have more outward directed forces. So the kneecap, rather than going in the center, starts going here and predisposes them to a dislocation. Again, where the patella tendon inserts here, that is also very important. So some individuals it's more inserted in this direction, and these individuals are also at a risk of recurrence of dislocation. So in addition to this, the last category and the rarest one probably, individuals whose hips are excessively rotated outwards, they are at a risk of recurrence of dislocation of the kneecap. So these individuals typically walk with a toe out gait. So these are the few common things which predispose individuals to a recurrence of dislocation of the kneecap, and when you meet your sports orthopedic surgeon, they will essentially advise a CT and MRI to find out these issues. Now let's look at the treatment. When you consider the first episode, as I said, since 80% of people don't have a recurrence, initially they are managed with a brace and a graded rehabilitation program, and by around 3 to 4 months they can resume sports. There is a subcategory of individuals who have excessive ligament laxity, and we need to work extensively on improving the muscle strength on these group of individuals. Now let's say somebody has a recurrence of dislocation of the kneecap, then what to do? So a recurrent dislocation of the kneecap is an issue that should not be ignored, because the more kneecap keeps on coming out and in, there is shear forces across the cartilage which can lead to cartilage wear and tear. So these individuals should be treated actively. If all the underlying anatomical factors are fine, then essentially the MPFL or the medial patellofemoral ligament, which is torn in majority of these cases, is repaired, which restores the knee stability. It is done through a mini open procedure. It is not an arthroscopic surgery, but it's done through a very small cut on the inner aspect of the knee joint. Now, suppose, let's say somebody has an abnormality where they have a knock knee. So, in that scenario, the knock knee is corrected, and what essentially is done is a procedure known as a DFO, or a distal femur osteotomy, where the knock knee is corrected to a normal alignment. Certain individuals who have recurrence of dislocation have, as I said, an abnormality in the shape here. So, in those individuals, this trough is again created, which helps restore the normal anatomy. Then there is a subgroup of individuals in which the tibial tuberosity, rather than being inserted in the center, is more inserted on the outward direction, and in these individuals we can change the insertion of the tuberosity. So, there are a lot of procedures which can be done based on what pathology the individual is having to correct and to prevent the recurrence of dislocation. All of these surgeries are open surgeries, and still, despite being open surgery, they are being minimally invasive, and people are able to resume sports typically by 4 months. Walking normally, obviously they can start by around 4 to 6 weeks. Normal regular activities can be started after 6 weeks. There is as such no bed rest. Sitting job and everything can be started within a week's period of time. But when we talk about return to play or return to sports, typically it takes 4 months after the surgery. So, this was what we had to discuss about recurrent dislocation of the kneecap. If you have any questions, you can send it across to us. We'll be happy to answer them. And if you liked our content, if you know somebody who is having a similar problem, do share, like and subscribe to our channel. Thank you.